Good day, guys. Today we're going to be looking at acute kidney injury, also known as acute renal failure, using the outline, introduction, rifle classification, pediatric rifle, other classifications, epidemiology, classification of AKI, etiology, pathophysiology, clinical evaluations, physical findings, investigations, and management. On the introduction, acute kidney injury or acute renal failure is an abrupt or sudden inability of the kidneys to excrete metabolic waste products as well as maintain normal body chemistry and fluid balance. That's in acute kidney injury. You always expect to have it sudden or abrupt, and there's always an inability of the kidneys to excrete metabolic waste products as well as maintain normal body chemistry. It is characterized by a reversible increase in blood concentration of creatinine and nitrogenous waste products and failure of the kidney to regulate fluid and electrolyte homeostasis. It is commonly associated with oliguria, that is reduced urine output. There's abrupt elevation in serum creatinine. There's dyselectrolytemia and acid-base disturbances. Over the last few decades, several different definitions have been used to define acute kidney injury. The more commonly used are based on urine output and or serum creatinine criteria. That is, you always expect changes in the urine output. That's urine output usually reduces, and serum creatinine is usually highly elevated in most cases. Therefore, it became crucial to establish a consensual and accurate definition of AKI that could ideally be used worldwide. That is when the ADQI rifle classification was made. In May 2004, the Acute Dialysis Quality Initiative Group for the Study of AKI published the consensual rifle classification for AKI definition. So what does rifle stands for? R is for risk, I is for injury, F is for failure, L is for loss of function, E is for end stage renal disease. That's it. Once acute kidney injury is left to progress without any interruption, it always results to an end stage renal disease. The rifle classification is based on serum creatinine urine and urine output evaluation. It considers basically three severity classes of acute kidney injury. We have risk, injury, and failure. There are usually two outcome classes, which are loss of kidney function and end stage kidney disease. Here, the rifle classification, we have a table summarizing everything you need to know. Under the risk, there is increased serum creatinine by 1.5, or there is decreased glomerular filtration rate by 25%. On the urine output, there is decreased urine output less than 0.5 milliliter per kg per hour by 6 hours. On the injury, we have increased serum creatinine by 2, or decreased glomerular filtration rate by 50%. For the urine output, we have increased serum creatinine by 2, or decreased glomerular filtration rate by 50%. When you can say its failure is you have increased serum creatinine by 3, or decreased glomerular filtration rate by 75%. On the urine output, you have urine output which is less than 0.3 milliliter per kg per hour in 24 hours, or anuria, that's total absence of urine in 12 hours, or if the baseline of serum creatinine is greater than or equal to 353.6 micromole per liter, or even greater than or equals to 4 milligram per deciliter. So when is it considered loss of function? When there is complete loss of kidney function for greater than 4 weeks. Yeah. An end stage kidney disease is considered when there is complete loss of kidney functions for greater than 3 months. Let's move to the pediatric rifle. In pediatric rifle, we also have a table summarizing what you need to know. You have stage, we have percentage reduction in glomerular filtration rate, we have degree of creatinine increase, we have urine output in milliliter per kg per hour. So the risk, a child is said to be at risk of acute kidney injury when there is 25% reduction in glomerular filtration rate. There is the degree of creatinine increases 1.5 times the normal baseline you should have. Then the urine output is reduced to 0.5 for 8 hours. It is considered to be injury when there is glomerular filtration rate reduction by 50%. The degree of creatinine is 2 times the baseline. The urine output is reduced by 0.5, is reduced to 0.5 for 16 hours. It's considered failure when there is glomerular filtration rate reduced by 75%. The creatinine increase is 3 times the baseline, and then urine output is less than 0.3 for 24 hours, or anuria for 12 hours. That's absence of urine for over 12 hours. What outcome do you usually have when this is left untreated or uninterrupted? There's always loss. Loss is considered when the failure is greater than 4 weeks, or the end stage kidney disease is or considered end stage kidney disease when the failure is greater than 3 months. We have other classifications such as Acute criteria, that's Acute Kidney Injury Network Working Group. We have KIDICO criteria, the kidney disease improving global outcomes. Work combine the rifle and Akin classifications in order to establish one classification of AKI for practice, research, and public health. KIDICO defines AKI as any of the following: increase in serum creatinine by 0.3 mg per dl or more within 48 hours, or increase in serum creatinine to 1.5 times baseline or more within the last 7 days, or when there is urine output less than 0.5 milliliter per kg per hour for 6 hours. Let's move on to the epidemiology of AKI. The worldwide incidence of acute kidney injury is poorly known because of underreporting, regional disparities, and differences in definition and case mix. Like in many developing countries, community acquired AKI is more common than hospital acquired AKI, though in Nigeria, while hospital acquired AKI are more common in developed countries than community acquired. So how do we classify acute kidney injury? It is customary to classify the causes of acute kidney injury into prerenal, intrinsic renal, postrenal. Prerenal, those are causes of AKI as a result of a blockage before the kidney or an infection before the kidney. Intrinsic renal, that's the pathology or whatsoever is causing the AKI is within the kidney itself. The postrenal, that is pathology or inflammation or injury occurring after the kidney. Here you have an image show indicating what prerenal, renal, and postrenal obstructions should look like. In prerenal, you have marked decrease in renal blood flow. In renal, you have damage within the kidney structures. And in postrenal, there's obstruction of urine output. So let's move on to etiology of AKI. We have prerenal. Here you expect to see circulatory insufficiency, dehydration due to gastroenteritis, vomiting, acute diarrheal disease, blood loss due to trauma, surgery, etc., severe burns, Then the intrinsic renal factors, we have acute glomerulonephritis, hemolytic uremic syndrome, drugs, incompatible blood transfusion, sepsis. In the postrenals, there's usually posterior urethral valves, stones, tumors, nodular hyperplasia, benign prostatic hyperplasia, etc. Susceptibilities. You expect to see this in the elderly, people suffering from diabetes mellitus, chronic kidney disease, dehydration or volume depletion, chronic diseases such as heart, lung, or liver. We have female gender, cancer, anemia. That are the main pathogenesis of AKI. There's decreased renal perfusion, there's hypoxic injury, endothelial dysfunction, oxidative stress, inflammatory infiltration, inappropriate complement activation, formation of microthrombi in blood vessels, cytokine-induced injury, direct tubular injury, obstruction, exposures. There's sepsis, critical illness, circulatory shock, burns, trauma, cardiac surgery, major non-cardiac surgery, nephrotoxic drugs, radioconstruct agents. So what's the pathophysiology of AKI? The pathophysiology of AKI is also subclassified into the prerenal, the renal, and the postrenal. In prerenal AKI usually results from a decrease in renal blood flow leading to hypoperfusion. The underlying pathophysiologic states may be due to a decrease in effective circulating volume or loss of vascular tone, or decreased cardiac output or blood delivery to the kidneys. Gastrointestinal tract losses or hemorrhage can lead to direct reduction in volume and decreased renal perfusion. In prerenal AKI, the usual cause is reduced blood flow to the kidneys. This could be due to anemia, loss of vascular tone, that's reduced peripheral resistance, increasing blood flow to the kidney. The cardiac output might be decreased due to trauma, injuries that resulted into severe hemorrhage or so. Alternatively, a redistribution of fluid may occur from either reduced oncotic pressure, that is when there is reduced albumin within the blood, or increased leak from vessels, that's systemic inflammatory response syndrome or sepsis, leading to suboptimal renal perfusion. You can see suboptimal renal perfusion here, indicating that there's usually decreased renal perfusion. In decreased renal perfusion, afferent arteriolar vasodilation occurs in response to prostaglandins, that's prostaglandin E and I, nitric oxide, and bradykinase to maintain glomerular filtration and renal blood flow. Concomitantly, the efferent arteriole is reflexively constricted by sympathetic nerve activation, endothelin, and activation of the renin-angiotensin system, leading to the production of angiotensin II, which is a potent vasoconstrictor. Angiotensin II causes efferent arteriolar constriction. The effects of renin-angiotensin system activation and antidiuretic hormone release result in increased sodium and urine reabsorption respectively. The reabsorption of sodium, urea, and water leads to oliguria, that's reduced urine output, and the characteristic urine findings in prerenal AKI. So this is the renin-angiotensin aldosterone system. Here the kidney is stimulated as a result of reduced cardiac output or hyponatremia. This results into the secretion of renin by the juxtaglomerular cells of the kidney. Renin now cleaves angiotensinogen from the liver. Angiotensinogen is converted to angiotensin 1. Angiotensin 1, which is converted to angiotensin converting enzyme, which is secreted from the lungs to angiotensin 2. Angiotensin 2, which is now the potent vasoconstrictor, will stimulate the release of aldosterone from the suprarenal glands of the kidney, will also stimulate uh, tubular reabsorption of sodium and chloride, also leads to a net increase in sympathetic activity. There's also arteriolar vasoconstriction, which results to increase in blood pressure. The posterior lobe of the pituitary gland is being stimulated to secrete antidiuretic hormone. Antidiuretic hormone in turn causes water absorption in the collecting duct of the kidney. You should also remember that aldosterone secretion by the adrenal gland cortex would result into overall tubular sodium chloride reabsorption and potassium excretion as well. There's also water retention. This is all about renin angiotensin aldosterone system in the pathophysiology of prerenal AKI. So next, we'll look at the intrinsic pathophysiology of intrinsic AI. Intrinsic AI refers to direct renal parenchyma damage or dysfunction. Categories include AKI associated with tubular, interstitial, glomerular or vascular damage and nephrotoxin exposure. A common cause of intrinsic AKI is transformation of prerenal AKI to acute tubular necrosis after prolonged hypoperfusion. The damage seen from prolonged hypoperfusion can range from mild tubular injury to cell death. Most intrinsic acute renal failure cases are associated with acute tubular necrosis from prolonged ischemia or toxic injury. Alternatively, a redistribution of fluid may occur from either reduced oncotic pressure within the blood or increased leak from vessels, as systemic inflammatory response syndrome or sepsis, leading to suboptimal renal perfusion. In decreased renal perfusion, afferent arteriolar vasodilation occurs in response to prostaglandins, as prostaglandins E and I, nitric oxide, and bradykinins to maintain glomerular filtration and renal blood flow. Concomitantly, the efferent arteriole is reflexively constricted by sympathetic nerve activation, endothelin, and activation of the renin-angiotensin system, leading to the production of angiotensin 2. Angiotensin 2 causes efferent arteriolar constriction. What are the clinical evaluations? A quick history is taken to determine the likely precipitating cause: diarrhea and vomiting, bleeding from accidents, circumcision, etc., burns and fluid loss, body swelling, hematuria, that's blood in urine, following antecedent sore throat or skin infection, ingestion of drugs or poisonous agents, dysuria, poor urinary stream, abdominal pain, fever, convulsions. Symptoms directly attributable to renal failure include oliguria or anuria, that's oliguric phase, body swelling, tachycardia, dyspnea, convulsions, coma. What are the physical findings in AKI? There's loss of skin turgor, dry buccal mucosa, sunken eyes, delayed capillary refill, small pulse volume, low blood pressure, depressed anterior fontanelle, elevated blood pressure, tachycardia, and edema. What are the investigations to be carried out? You do urine dipstick test for protein, blood, urine specific gravity, sodium content, urine microscopy for red blood cells, CAS, leukocytes, serum electrolytes, urea, creatinine, serum proteins, total and albumin. You do full blood count, you do blood culture, you do anti-streptolysin O titer, you do serum complement C3, throat swab, skin swab for microscopy, ultrasound, that's for kidney, urethra, and bladder. What are the goals of management? The goals of management are maintenance of electrolyte balance, maintenance of fluid balance, treatment of causes of acute kidney injury, treatment of hypotension, give adequate nutrition, treatment of emerging complications, prevention of further nephrotoxicity caused by harmful drugs, poisons. In patients with depleted circulatory volume, give fluid kidney challenge with 20 ml per kg of normal saline over 30 minutes or 1 hour for infants. Can be repeated if no urine in 1 hour, and furosemide 2 milligrams per kg can be given intravascular as well. If urine is passed and vital signs are corrected, continue rehydration process. Subsequent days give equivalent of previous day's fluid output. That's the urine plus insensible loss. In hypovolemic states, like in oliguric phase of acute glomerular nephritis, challenge with furosemide 2 milligrams per kg intravascular. This can be repeated. Restrict input to insensible loss, which is 400 ml per day. Subsequently give equivalent of previous day's fluid output. That's urine plus insensible loss. Correction of electrolyte derangement. Hyperkalemia is the most important electrolyte derangement. Electrocardiogram monitoring is useful in evaluation. For levels above 6.5 millimole per liter, give 8.4% sodium bicarbonate 2 millimole per kg over 20 minutes to correct acidosis. Insulin 0.1 unit per kg per hour IV as continuous infusion drives potassium into the cells. Give 10% calcium gluconate intravenously 0.5 ml per kg over 5 to 10 minutes. It ameliorates the toxic effect of potassium on the myocardium. Give salbutamol 4 micrograms per kg IV over 20 minutes. 8 shifts of potassium into cells. Can also be given by nebulizer. Sodium polystyrene sulfonate can be given orally with sorbitol or rectally as enema 1 gram per kg or dose twice daily. It exchanges potassium for sodium. Hypertension is a very important physical sign that can result in hypertensive encephalopathy. Severe hypertension is managed with hydralazine 0.1 to 0.3 milligram per kg IV over 5 to 10 minutes. Dioxazide 1 to 3 milligram per kg IV bolus. Labetalol 0.2 milligram per kg IV bolus over 2 minutes. Nifedipine 0.2 to 0.5 milligram per kg oral. Nutrition. Give adequate caloric intake, at least 100 kilocalories per kg per day. Protein diet beginning with 0.5 gram per kg per day on the second day. Low salt diet. Avoid food items rich in potassium and phosphates. Parameters to be monitored. Strict fluid input output chart. Daily dipstick urinalysis. Daily weighing. Blood pressure. Pulse at least 2 hourly on day 1. Temperature. Daily EUC creatinine. Dosing of drugs, especially those excreted by kidneys, must be modified in quantity and frequency. If the patient deteriorates in spite of these measures, then dialysis, either peritoneal or hemodialysis, has to be carried out. What are the indications for dialysis? Fluid overload with pulmonary edema and congestive cardiac failure refractory to treatment, uncontrolled hypertension, hyperkalemia unresponsive to conservative management, serum urea greater than 150 milligram per dl, serum bicarbonate less than 12 millimole per liter, clinical deterioration with convulsions and coma, multiple organ failure. Determined by types of precipitating cause, promptness and adequacy of management. Most patients recover if properly managed. Thanks for listening.